कभी रिग्रेट हुआ कि आप एम्स नहीं गए?
There was a regret on the back side of the mind कि हाँ AIIMS जाना चाहिए था, but it was good that I came to JIPMER for my MBBS.
How were the JIPMER days?
Where you meet lot of people which teach lot of things about the life. You understand how life goes on later.
JIPMER internship.
You are included in the management part of the patient also, not only in the clerk work.
सबसे frequent कौन से cases देखते थे आप as JR1?
Whether it is drowning, burns, or any medical or surgical emergencies.
Isn't it emotionally draining?
Yeah.
How did you manage that?
Emotionally draining होता है first year में, but I feel कि with the time as the training goes on, you learn how to deal with it.
Emergency medicine के लिए कौन से young doctors best suited है?
People who can multitask for a short time, even work in that flight and fight response.
How do you see AI changing this branch in the next 10 years?
In this branch, I don't feel कि AI doctors को replace कर सकते हैं, and I don't feel कि कोई और branch में भी ऐसा हो सकता है.
Post doing your MD, आपकी पहली salary क्या थी? Hey guys, welcome to the Nachiket Bhatia Show. Our today's guest is a frontline emergency medicine doctor, currently serving as a senior resident at AIIMS New Delhi. He completed his MD in emergency medicine at JIPMER, is an AHA instructor and ATLS India faculty, and has authored multiple indexed international publications. He is also a creator of Life on the Frontline, Substack series that captures the chaos, humanity, and lessons of emergency care in India. In this episode, we'll explore what it really means to be an emergency physician in our country. The adrenaline, the exhaustion, the identity crisis, and the courage it takes to work where every second counts. Let's put our hands together and let's welcome our young doctor, Dr. Arihant. So welcome Dr. Arihant to the Nachiket Bhatia Show.
Thank you very much.
मैं एक बात सच बताऊं, आई एम सो इम्प्रेस्ड. आप नाइट शिफ्ट कर आए हो, डायरेक्टली यहाँ पे आए हो और नाइट शिफ्ट करने वापस जाओगे.
Correct.
तो अभी किस स्टेट ऑफ माइंड पे हो आप?
For me, now I am in this system, so I am very much into this. Ki you have little bit of rest, then you have to think the best of your mind, and then again go to little bit of rest and off time. And sometimes you get into the system where in the flight and fight response, where lot of crisis is there, you have to give your best opinion. So I feel this is the perfect timing for an EM physician to give the answers to a branch about emergency medicine.
So Dr. Arihant, हमारी ऑडियंस को बहुत पसंद आता है when a young doctor comes in and tells the realities of the field. मैं यही उम्मीद कर रहा हूँ कि आप हमें सबको बिल्कुल एक ऑनेस्ट रियलिस्टिक वर्जन दोगे, because you have been into JIPMER, you have been into AIIMS, you are currently an AIIMS CSR, and you have seen the ins and outs. So
Correct.
let's get into it. आपकी इनिशियल जर्नी कैसे रही? How did you get into the field of medicine? और JIPMER से आपने MBBS करी, again an amazing feat.
So starting before MBBS, this was my, most of the people take MBBS based on some peer pressure or something, but for me it was my own decision, because I have seen definitely there is a requirement of a doctor in a family. Plus it gives you a personal perspective of you knowing ki what is actually happening with your body. So for my loved ones, my family, my friends, if there is somebody like this who can give them honest advice related to their health, which is very important in current lifestyle, that is why I thought कि हाँ मुझे MBBS करना चाहिए. So I chose MBBS and I got into JIPMER.
How were the JIPMER days? UG especially.
UG days in JIPMER is, it is very, what do you say, since I was away from home, so it was a different experience for me. Like it was the time when I was between 18 to 22 of years of age, and I was in a new city with new people. So I got to explore life in a new way. Like away from, if you are in hometown, you have this, you are still close within the boundaries. Like you won't get to explore the life outside the hospital. Maybe I would have gone to the hospital, I would have come back home, and then I would stayed with family. Being in JIPMER, I got to experience the hostel life, where you make long-term friends, where you meet lot of people which teach lot of things about the life. You understand how life goes on later. You also understand ki life is not only about what professionally you are doing. There is more to life. There is more to life, like in the sense there is personal life, there is life with your parents, and there's a lot of traveling, there's a lot of things in the nature. So it introduced me to the other aspects of life also, which I think that if I would have been in my hometown or nearby my hometown, I would have missed. So it made me evolved as a person also, not only as an academic person, but as a personal, it gave me a personal touch too.
What makes JIPMER special?
What makes JIPMER special? It's a tough question. JIPMER, talking about the MBBS curriculum, the curriculum in JIPMER at MBBS level is very good. The academics are too good. So most of the times the people have complaints in MBBS curriculum is that they don't get too much of academics. They don't get too much of clinical experience. But JIPMER has that in the first priority. So start from the second year of your MBBS, you learn to go into the medical field. You learn to, initially you will be just an observer, which is called as clerkship. I think it happens in the third year of MBBS. Then soon you are introduced to the medical department. You are introduced under the guidance of the professor level teachers, and they will teach you. They will teach you clinical examination bedside. They will teach you how to take history. They will even teach you how to break bad news, which is, I don't think any other MBBS curriculum, maybe AIIMS does that, but other curriculum does that. It really makes you evolved as a human, and it brings more aspect to life. With medicine, there is great academics, there is great extracurricular activities there. We have our annual fest called Spandan. We get to organize a national level conference also for UG. So there are multiple things which you get to learn being a JIPMERite as in a MBBS setup.
When did you start preparing for NEET PG or INICT?
INICT, I actually have not prepared that much. During INICT, most of the people will do that in internship. But JIPMER internship is not about you will have free time. In JIPMER internship, it is more of a clinical work. So you will always be on the floor.
JIPMER internship, yes, please.
JIPMER internship is more about floor work. So most of the institutes in India, the internship part is really neglected. Like बहुत सारे centers ऐसे हैं इंडिया में जहाँ पे internship के time पे people don't go only. So there is no initial introduction to the medical life to them. Some people will not even know how to put an IV line. Some people won't even know what is NS, what is RL. So even some PG people who are coming to JIPMER, you will know that during internship they have not gotten enough exposure to the basics of the medicine, I will tell. In JIPMER, that part is great. Like from internship, you have to attend the rounds. You have to you have to do some work also, like taking samples. But along with that, you can learn also. You can learn about different specialties. While you are rotating in that particular specialty, you can actually learn how the patients are managed. What are the various factors that they take during the patient management. They will include you in the clinical rounds also. And if you have any doubts, anything, you can ask them along with the PGs. So you are included in the management part of the patient also, not only in the clerk work, which is like taking samples, but if you're interested, you can take part in the patient management also, which is now evolving slowly and becoming more into the patient management part and less of the clerk work.
आपने कब सोचा कि आपको emergency medicine branch लेनी है?
So starting of the internship, I was like, I have to take MD medicine or MD pediatrics. That is why most of the people are like that. या तो कुछ सर्जिकल ब्रांच चाहिए या कुछ मेडिकल ब्रांच चाहिए. मेडिकल ब्रांच है तो मेडिसिन या पीडियाट्रिक्स, सर्जिकल ब्रांच है तो जनरल सर्जरी या फिर स्पेसिफिक ऑप्थेल ENT किसी को लेना है तो वो. If somebody wants to go little bit away from the clinical dermat and totally away from the clinical, it is radiology. So I didn't know about the branch only. There is a branch called emergency medicine post like in the starting of the internship maybe. Then in internship we have a rotation in emergency medicine. So before that rotation I had 2 or 3 moments which happened with me. One of the moment I have gotten it published also. That is one of the narrative story I have gotten published in EMJ. There was one incident in a flight when I was traveling from Jaipur to Chennai. So there was a baby who collapsed on the flight. So obviously the crew, they were trained in BLS. They were trained in pediatric BLS. BLS is basic life support they give. So they were trained how to give BLS differently in a child. But still they asked if any doctors is available on the call, please come. So When they asked that, there was a senior cardiologist who was there. There was a dermatologist. There was a radiologist. There was one of PG trainee in medicine. He was not MD medicine, but he was like second year or third year PG trainee. And I was there as a start of my MBBS. So I won't even call myself as a doctor that time because I knew nothing about it. So I was just standing behind in the crowd like other people, but maybe in the front line of the crowd, not in the back line. So I remember exactly that the nurses were giving pediatric CPR properly, but there was something that the cardiologist was not sure whether this is the correct way, whether this is the wrong way. So he gave some instructions which were not correct according to the pediatric BLS algorithm. But nurses told him that this might be correct because what we were trained is this. But since he is a cardiologist, so they had to follow that. That time I didn't know that it was wrong. But when I went through the rotation in emergency where they teach you PALS, the pediatric advanced life support, and the CPR, then I got to know that it is actually what the crew members were doing was correct and what the cardiologist was telling might not was correct. I'm not telling that he didn't know. I'm not telling that he was not sure what has to be done. But I'm just telling that he was not ready to deal with that emergency situation. So in India, everybody is rushing towards super specialties right now. So they finish one MD or they finish MS and they go for MCH or this. But nobody is seeing body as a whole. There's no person who actually sees body as a whole, all the systems together. Previously, there used to be general physicians. People used to stop after MD medicine and they used to open OPDs and they used to see bodies as a whole and see different parts, different organs, interactions, and likely they used to treat. But nowadays, it is more of an organ-specific medicine which is happening. So I'm not telling that super specialty is wrong. I'm not telling that they don't know how to treat. But I'm telling they're not ready for treating the patient when it is little bit chaotic. They take a break, they pause, they think about the SOPs, they think what can be done in this situation. But think about this, if there is some doctor which is available there who has practiced this multiple times before, who has gone through the same situation multiple times before, now these things are in his muscle memory. He can save the patient better than the cardiologist or than the particular specialty. That is where emergency medicine comes in. So emergency medicine is not about ki you have to know everything in all the branches, but it is about you should know enough to save the person when it is needed the most in the initial phase of the life. And it is written in many literature evidences also that time really matters, especially when the patient is the sickest. So if you treat the patient correctly in the initial part of the time of his deterioration, you can actually prevent his further deterioration and bring the patient back to life. So there are certain instances like this which thought कि कुछ तो इंडिया में medical system में gap है, and I was lucky that time only I had to go through the rotation in emergency medicine also. So I saw some great seniors there. There was that time SR in emergency medicine, Dr. Guna, Dr. Ajay. They were great leaders. They used to be on the floor. They used to manage the entire floor. They used to see the sickest of the patient. They used to, in the same time, they used to manage 3 or 4 sickest patient and be calm on the floor. So that literally made me feel ki, this is what suits my personality. Then I did more research on it during the time of my internship. And in the final part of the internship, in the last 2-3 months, I prepared for AIIMS. And then I got a seat in MD Emergency Medicine. So before that, I had a plan of doing the non-academic JR course in AIIMS. But then when I got MDEM in JIPMER, I thought of joining directly for MDEM.
अच्छा आंसर था ये काफ़ी ना. I like the journey. और ये प्लेन वाला इंस्टेंस तो ऐसा होता है which is like a life changing incidents.
Correct.
मुझे तो लग रहा था कि आप मुझे कहोगे कि उनको नहीं आता तो फिर मैंने बचाया जाके.
नहीं. I was not trained enough for that. But I feel कि अगर उस टाइम ऐसे बहुत से incidences होते हैं कि जहाँ पे if somebody well trained, more trained in that particular situation is there, we can save lot of lives.
Yeah, same goes for everything, na. You can't take the place of the cardiologist.
Correct.
The cardiologist can't take your place.
Correct.
Goes for every surgery.
So there is specific role for specific people.
I think I like the way that you said that it suits your personality. Or in a very initial stage, you knew कि this is the kind of work that suits me, because 90% of the people don't know their personality. कोई चाहता है, लोग चाहते हैं कि let's suppose it's not आई मीन ऑफकोर्स जिपमर हो गया, पीजीआई हो गया, इवन एम्स की अगर हम बात करें, केजीएमयू की एमडी मेडिसिन हो गई। अगर आपको फिजिशियन बनना है, आपको केजीएमयू जाना है, तो आपको पहले 22 घंटे दिन में 365 दिन काम करने की क्षमता भी होनी चाहिए।
करेक्ट।
उसके बाद ही आप जा सकते हो। क्या आपकी ये पर्सनालिटी है कि आप 22 घंटे काम कर सकते हो, गाली खा सकते हो, बिना नींद के काम कर सकते हो?
करेक्ट।
इफ़ यू कैन नॉट, देन दिस इज़ नॉट द प्लेस फॉर यू।
करेक्ट।
जिपमर का बताओ, जब जिपमर में आप JR1 बने,
हाँ,
तो आपके साथ पहले साल में क्या क्या हुआ?
तो फर्स्ट ईयर में जब व्हेन आई एंटर्ड जिपमर में रेजिडेंसी, सो आई वाज फुल्ली इन सर्वाइवल मोड, प्योर सर्वाइवल मोड। तो आई स्टिल रिमेंबर द इंसिडेंसेस कि कभी कभी ऐसा होता था कि शिफ्ट खत्म होने के बाद में स्टिल रिमेंबर द फेसेस ऑफ द पेशेंट्स। नाइट में ड्रीम्स में इट विल कम कि दैट पेशेंट हैज़ कम, उसका वो इन्वेस्टिगेशन हो गया, तो सडनली विल गेट अप इन द नाइट। तो इनिशियल पार्ट ऑफ द ट्रेनिंग इज रियली हार्ड in emergency medicine. Nobody, not everybody can take it. That's why I'm telling कि especially you should know कि कौन सी फील्ड तुम्हें चूज करनी चाहिए।
आपका टिपिकल डे कैसे जाता था फर्स्ट ईयर के अंदर?
Typical day in first year will be, so in emergency medicine residency in JIPMER, we used to have shifts. So shifts used to be from morning 8 a.m. to 2 a.m., 2 p.m., 2 p.m. to 8 p.m., and then night shift 8 p.m. to 8 a.m. So in JIPMER emergency medicine, there are not enough JRs. Like JRs are there, but there are not enough JRs to get offs. So we have to continuously work. We don't have any offs in between. So I'll have to work. Suppose I start with morning duties, so I have to do 2 morning duties. Then I have to do 2 night duties. Then after the night duty, next day afternoon I have to come back. So suppose after night duty, I am attending rounds. By 11 rounds will get over, and I have to come back to duty at 3 o'clock. Then I have to do 2 afternoon duties, and then again this schedule goes on. So most of the time there is no break for you. In the initial first year mein you don't know how to manage the patients properly, so you are mostly guided by the seniors. So what patient requires 1 hour of management, you might take 2 or 3 hours in that also. So what shift is for 6 hours, it might become 8 hours or 9 hours. That is how it goes. So you don't get personal time in the first year. So it is poor. And one more problem in first year is you have lot of energy, but you don't know how to channelize that properly. So to which patient you need to give more time, which patient you need to give less time. This is how the first year goes.
आपके जो फर्स्ट ईयर में were the seniors supportive?
So I think in all the residency, in all the departments, in all the centers, there are some seniors who are too good. There are some seniors who are not that good. And there are some seniors which some people have told you that he is not good, so you also believe that he is not good. So in JIPMER, I had all the kind of seniors obviously, and I think all the people who go through residency have all the kind of seniors. Maybe one kind of senior becomes more heavy, but in JIPMER, there were definitely bad seniors also who will call you late nights to work, that something has been missed in the case sheet, you have to document that. So post night they will call you to come and document that and then come next day. But then they were very supportive seniors also. So if you go to them, they will ask what is the problem, what can you do about it. They will mentor you in a great way. Even the consultants there, they're very, so in most of the academic departments in JIPMER, it is a very big department. So the JR is not directly in contact with the consultants most of the time. So it is very difficult to connect to them. But JIPMER mein EM being an evolving branch, like initially when I joined, there were only 4 consultants and with an HOD, 5 consultants. So it was very easy to connect to them. So you can actually go and connect to the topmost person on the tier कि सर मुझे ऐसे फील हो रहा है कि आज मैंने कुछ सही नहीं किया या आज मेरा कुछ गलत हो गया, so please advise me on this. So there were very good mentors in that place which helped me shape to who I am today. One of the mentor I like to name also, there is Dr. Bala, who is consultant there. And you can ask anybody from JIPMER, even the people from the general medicine department, they will know him because that is the charisma he has. That is how he treats, how he mentors people. He will be good in academics and he will be good as a mentor also for you. So different consultants will in different mentorship roles in different part of the niche of the department.
Normally सबसे frequent कौन से cases देखते थे आप as JR1?
So JR1 में there is nothing like that particular case you have to see in JIPMER. So JR1 में there is no case distribution like in other departments there is case distribution.
मतलब आपके सबसे ज़्यादा cases कौन से आते थे वहाँ पे?
हाँ, तो JIPMER में emergency is a mixed emergency. So other than pediatrics and OG, all cases will come to the same emergency. So you get to see all the cases, whether it is an MI, whether it is a stroke, whether it is a trauma, whether it is a pediatric trauma, whether it is drowning, burns, or any medical or surgical emergencies, all comes to the same emergency department. And as a first year resident, you get to see all of them.
Mortality तो काफी heavy रहती होगी.
Mortality काफी heavy रहती, correct.
Isn't it emotionally draining?
Yeah.
How did you manage that?
So emotionally draining होता है first year में, even second year में होता है. But I feel कि with the time, as the training goes on, you learn how to deal with it. And I still feel nobody knows perfectly how to deal with it. But then yeah, you know how to survive in that. But that comes in maybe the later year of the part. Initially in the first year, you're not more into that part of the thing. First year में there might be one case or two case that you take too deeply, or you over empathize on it, and then you go and talk to your seniors. Then seniors will help. That situation will be there. But when you become like you have a balanced empathy situation कि हाँ मेरे को इस पे over empathize नहीं करना है, मेरे को इस पे कम सोचना है, तो वो सब डेवलप होता है सेकेंड ईयर से. आई विल फील सेकेंड और थर्ड ईयर व्हेन यू गो मोर इनटू द एडमिनिस्ट्रेशन एंड लीडरशिप वर्क.
तो फर्स्ट ईयर में कैसे मैनेज किया जब पहली डेथ देखी?
तो फर्स्ट ईयर में जब पहली डेथ देखी तो ऑब्वियसली इट इज़ वेरी सैड. एंड इनिशियली यू डोंट हैव दैट इमोशनल बैकड्रॉप टू डील विद इट. सो दैट टाइम आई रिमेंबर इट वॉज माई केस. तो जब मेरा खुद का केस का पहला डेथ हुआ तो आई हैड माई सीनियर टू बैक मी ऑन. सो ही टोल्ड कि you did your best. It might need led into a failed resuscitation, but no problem. We will debrief about it. हम लोग इसके बारे में सोचेंगे, हम इसमें क्या खूबियाँ थी, क्या खराबी थी, हम इसमें कैसे और इम्प्रूवमेंट कर सकते हैं. And then finally, so that we prepare ourselves for the next best. So there was someone to tell me this, but I feel most of the people don't get these type of seniors or mentors जो आपको personally आके बताएं कि तुम इसको ऐसे डील करो. So this is what emergency medicine also has. There is a component after every resuscitation we debrief with each other. It is called the art of debriefing, where we discuss कि इस resuscitation में क्या हुआ. We discuss what were the positive points, what were the negative points, and we make a feedback loop कि इससे हम ये सीख सकते हैं ताकि we can put it in the next resuscitation and we can help the patient the most.
कभी आपको ऐसा लगा since JIPMER is in South, when you entered the college, there must be a language barrier.
Yeah.
कभी आपको ऐसा लगा कि that the system has treated you like an outsider? Or you face a little bit of a bias because of language?
I don't think that is there in the JIPMER. The language barrier will causing you to learn less, or the
तो उनकी
teachers.
teaching language क्या है?
Teaching language is English.
अच्छा.
Yeah. And the people who are there from Tamil Nadu or people who know Tamil, they will really help you. They will take an extra effort to teach you. I remember there was one of my batchmate. He was from Andhra. So he has learned Tamil and he has recorded lessons for Tamil, what he has learned for the other batchmates also. So there were such great people. So that was not any barrier.
I think the level of intellect at JIPMER, your batchmates, the intellect, it must be great.
Yeah, correct. All of them are at big institutes right now. All of my batchmates, some are in AIIMS doing MD, some are in PGI, some are continuing in JIPMER, some have gone outside as USMLE, some have done PLAB. And
आपने AIIMS भी ऐसा, you are doing SRship in AIIMS,
yeah.
You have done your PG in JIPMER. क्या difference लगा दोनों के अंदर?
Differences there, definitely differences there. In JIPMER, it is a trauma center and as well as a main emergency same. While in AIIMS, the trauma center is different and main emergency is different. First thing. Second thing, patient load and case diversity is almost same. Maybe because of the geographics, little bit case changes. Like more of poisoning cases comes in JIPMER. Here, less of poisoning, more of other cases come. But if you see per healthcare worker, the caseload, it is definitely more in JIPMER. In AIIMS, there is more people to help you. So there is different technician to see the ventilator setting, to optimize the ventilator when you tell them. There is a different person. There is a separate shifting team for the patient. But in JIPMER, there is not that much staff. So there is a doctor, there is a nurse, there is 2 or 3 DRL workers and other staffs. So you among the team only have to decide while working on this work, you have to work for the other thing also. So I will only have to set up the NIV. I will only, maybe the nursing staff helps me. Then I will only optimize. So per healthcare worker, the patient load is much larger in JIPMER. Here per healthcare worker, the pressure on the JR or the SR is less. So that makes a difference. But in a branch like emergency medicine, I feel when you are training, there are both phases to it, the positive phase as well as negative phase. You need to go through this pressure because in the end, in the situation, there might be some crisis, where you where you only have very less resources to treat with the people. So I feel ki that worked as a positive side for me in JIPMER. Having less resources, having to treat more people in less resources, and prioritizing कि this resource is better suited for this patient right now. This patient can wait. So that decision making came because of that working nature. But yeah, many people, other residents might not agree with it. They might feel ki it is overburdening. Yeah, it becomes overburdening sometimes. But yeah, it has some positive aspects of it too. Because I feel ki whatever bad happens in the life, there is always some positive associated with it. So I try to concentrate on that so that I can feel less bad about it. So this is what I follow.
So जब आप JR2 बने
हाँ हाँ
अपनी रेजिडेंसी में,
yes sir.
तो आप किस टाइप के सीनियर बने अपने जूनियर्स के लिए? Honestly.
Honestly, I'll tell you कि it depends. It depends what junior needs, what kind of senior. So some juniors will be there who will be very interactive, who will take care of their patients properly. But sometimes there will be some juniors who will cross the limits. Like एक पेशेंट को ये चाहिए था बट उसने नहीं किया, आपने एक बार बता दिया नहीं किया, 2 बार बता दिया नहीं किया, बट देन ही रिक्वायर्ड सम गाइडेंस. सो समटाइम्स when you are very overburdened, when you yourself are seeing lot of cases and you have a as a new to second year, you suddenly get a responsibility of a junior also. So you might overspeak, you might become angry on them. But I felt it is good कि बाद में जाके when the situation little bit calms, you go and tell कि ऐसा हो गया था. If I was wrong from my side, I go and tell or something. I empathize with them. I will go and tell them sorry कि शायद मैं ज़्यादा बोल गया या शायद मैंने ऐसा कर दिया. बट कभी कभी ऐसा होता है कि यू डोंट गेट टाइम फॉर दैट ऑल्सो, बट समहाउ यू ट्राई टू डू द बेस्ट वॉट यू कैन डू. एंड समटाइम्स ऐसा होता है कि इतना ज़्यादा काम होगा कि तुम भूल जाओगे कि हमने ऐसा भी कर दिया था, और तुम्हारे माइंड में नहीं आएगा कि तुम उस बारे में सोच नहीं पाओगे कि हाँ मैंने गलती से उस जूनियर को ज़्यादा बोल दिया, इतना मुझे नहीं बोलना चाहिए था.
एम्स की एसरशिप का बहुत बड़ा ब्रांड नेम है.
हाँ,
कि आपने एम्स एसरशिप करी है. इट कैरीज अ ब्रांड नेम, a lot of reputational value also while applying for corporate especially. So do you think it basically it matches the brand value and the AIIMS association?
Yeah, correctly. Definitely it matches because I will tell AIIMS also has some flaws. Definitely it has also flaws.
क्या flaws है?
There can be multiple flaws कि कभी कभी एडमिनिस्ट्रेटिव की साइड से कोई काम नहीं होता है. There is lot of political things involved कि कभी politician का केस आता है तो you have to take it, you have to give the bed to them. ऐसा चीज़ें हैं, वो हर जगह होता है. बट AIIMS has good points also. So if you see the proportion of good points and negative points, there are multiple good points which brings you to the correct, the adequate branding it gives you. Plus the case diversity, the infrastructure, the research opportunities, which they are much better in AIIMS. In India, we don't, most of the medical institutes, we don't focus on the research that much. So AIIMS and JIPMER are some of the institutes which focus on research even from the UG time. So there are multiple scholarships you can take. You can present your paper outside internationally with some scholarships. That and all awareness is not there in other colleges or other things. But this opportunity is provided better by AIIMS and JIPMER. So you get to know all about all this. And later maybe when you know about all this, you can tell to the other people also and spread more awareness about it later. So yeah, definitely that brand name is there.
Emergency medicine के लिए कौन से young doctors best suited है? And which are the types of personalities who should absolutely avoid this branch?
Okay, so this is very important. Why? Because how it is not about 3 years of residency you are going to do. So you choose a decision based on how long you can survive in that department, because this is a lifelong decision. It's a very crucial decision in any person who is practicing medicine. So who can take this branch? People who can multitask for a short time and effectively. People who can even work in that flight and fight response, and people who can calm themselves down even in very chaotic situations. They might not know this initially, but if they work on it, they can develop that things. The people who should not take it are the people who are thinking they want calmness everywhere. They want everything to be organized. They want things to happen orderly. Like ऐसा होना है तो ऐसा ही होना है. अगर डायबिटिक पेशेंट का ये कॉम्प्लिकेशन होता है तो यही कॉम्प्लिकेशन होना चाहिए. डायबिटिक पेशेंट शुड नॉट कम विद अदर मे बी MI और ऐसा कि मल्टीपल सिस्टम्स इन्वॉल्व नहीं है. तो इफ़ यू कैन थिंक पेशेंट एज अ होल, if you can multitask, and even if you can work in a chaotic situation. Plus, one more very important factor is communication skills. Why communication skills are important? Because you are also in the worst state of your mind. The person and their attenders might also be in the worst state of their mind, because people come very sick rolling in emergency department. So you should have adequate communication skills to deal with the patient, to deal with your fellow staff, and to calm yourself down also in difficult situation. Yeah, certain qualities might not be there initially in the present, but if you feel ki I can do that, then I'll definitely suggest that is the best branch. And why it is the best branch is there is shift based work. After the shift, nobody will bother you. Nobody will call you about anything. Once your shift is done, you have given your handover to the same competent level of person, and he will take care of the stuff later. So why I feel it is important for me, if you ask about me, is I get to do things which are other than medicine also. So I don't want my life entirely to be on the medicine.
So are you saying that this branch has good work-life balance?
Yeah, I'll say it has a good work-life balance.
Seriously?
Yeah.
All right. Matlab, I've always
Yeah, that is what.
listened
There
to
are lot of things which people think is about this branch, but they don't know what actually is
So
happening
that's
in
my
the
next
branch.
question. क्या सबसे बड़ी myths है इस branch के बारे में जो MBBS students को लगता है कि वो सच है?
So I will tell 2-3 big myths. First myth is people think that it is a triaging branch. People think it is a casualty. People don't know what is actually EM, emergency medicine. So there is a very good anecdote written in one of the literature which tells transition from casualty to the emergency department, and it is written by somebody in the Western emergency department, like in the US. So it tells कि जब पेशेंट एक सिक पेशेंट किसी के डोर पे आता है, तो ये दिस इज अबाउट यूएस, जहाँ पे ऑलरेडी प्री हॉस्पिटल इज वेरी गुड, दे विल गिव सम केयर इन द प्री हॉस्पिटल पार्ट. इन इंडिया द पेशेंट इज कमिंग सिक, already he is very late. Why? Because first he won't come and show you. Second, he won't know only that something is wrong with him because there is no awareness. Third, there is no pre-hospital. Pre-hospital system is very bad in India currently. So the patient rolls in very sick and very late in the disease process. The continuum of disease is very late. And us patient ko somebody sitting in the casualty which used to be there previously, still it is there in some of the departments in the India where there is no proper EM setup. There will be a person called CMO sitting there. He is a casualty medical officer. Who is that CMO? Is the junior most person in some department who weekly gets posted in that position. Like they will have 2 days in a week from orthopedics somebody is coming, 2 days in a week from radiology somebody is coming, 2 in a week general medicine somebody is coming. So these are the people who are less experienced to deal with that situation. And the sickest patient you are letting them to deal with it's very contradictory. The sickest person should be treated by the somebody who is well trained to manage them. So that's where emergency medicine steps in. कि आपको है कि you should know कि इस patient के साथ क्या करना है. You should actually identify कि ये patient actually cardiac arrest में. Most of the people don't know only how to identify cardiac arrest. You should know in next 10 minutes क्या patient को save कर सकता है. You should know कि next 15 to 20 minutes what I can do with the patient कि ये पेशेंट इतना सेल्वेजेबल हो जाए कि इसको किसी और डिपार्टमेंट पे रेफर कर सके. सो दैट इज व्हाट इज द ट्रांजिशन फ्रॉम कैजुअलिटी टू इमरजेंसी डिपार्टमेंट. दैट इज वेरी इंपॉर्टेंट फॉर पीपल टू नो दैट इट इज नॉट कैजुअलिटी, इट इज इमरजेंसी डिपार्टमेंट, एंड इट हैज लॉट ऑफ थिंग्स which still people don't know about. Second thing about the myths about EM is work-life balance. We talked about this point. अभी हमने डिस्कस किया वर्क लाइफ बैलेंस. तो पीपल थिंक कि इमरजेंसी मेडिसिन डिपार्टमेंट में देर इज नो वर्क लाइफ बैलेंस, बट आई विल टेल यू दे पीपल जस्ट ओनली नो अबाउट द 3 years of residency. They don't know what happens after. So it is purely a shift based work. So you will be in 6 hours of shift. After that you are free. You can do whatever you want to do with your personal life. And as you become senior, that 6 hours will be 6 hours only. Initially when you are learning phase in the residency, that 6 hours might become 8 hours, giving handovers, doing extra procedures to learn hands-on. That becomes 8 hours. But as you become more and more senior, it is 6 hours work means 6 hours work. Then you can do your personal life. You can go out with your family. You can go into something else. You can read more about finances. You can read more about traveling. You can do a lot of stuff. So that is why I feel ki this branch is one of the branch which gives a good work-life balance for a PG student to take in.
कभी ऐसा हुआ है कि that because emergency department again if it includes triage, it includes casualty.
Yeah.
सबसे ज़्यादा मोर्टेलिटी वहाँ हो रही है? it is one of the areas which is most prone to violence for doctors.
दैट इज करेक्ट.
तो कभी आपके साथ हुआ है ऐसा?
मेरे साथ नहीं हुआ, बट आई हैव एक्सपीरियंस्ड, आई वाज देयर व्हेन इट वाज हैपनिंग विद समबडी एल्स. आई हैव एक्सपीरियंस इट फर्स्ट लाइन कि कब वायलेंस होता है. तो वन ऑफ माई सीनियर कंसल्टेंट एम्स टेल्स दिस दैट वायलेंस इज नॉट द प्रॉब्लम विद द डॉक्टर, नॉट द प्रॉब्लम विद द अटेंडर, इट इज़ द सिस्टम फेलियर. So how it is a system failure is, first of all, there are multiple factors involved in that. So there is a doctor, there is a patient, and there is environment, infrastructure in the system. So the doctor in the entire curriculum is never taught about communication. He is never taught about how to break bad news. He is never taught about how to control your emotions, how to empathize with the patient. It is nowhere in the curriculum, in the medical curriculum. If somebody wants to learn about it, he will go extra hand and only learn about it कि हाँ मुझे चाहिए ये, मुझे बात करना है. And when you come to an emergency department, you get to see the patient and their attendants in the worst. उस बात पे अगर किसी के पास कम्युनिकेशन स्किल्स नहीं है तो ऑब्वियसली कुछ ना कुछ ऐसा ट्रिगर पॉइंट होगा कि कोई ना कोई उससे ट्रिगर हो जाएगा. When we come to the patient and patient attender sides, they don't have any awareness about the emergency department. So sometimes people even feel कि patient को अभी तक कोई ट्रीटमेंट नहीं मिला है क्योंकि वो अभी भी emergency department में है.
मैं इस बात से शायद सहमत नहीं हूँ कि कम्युनिकेशन आए या ना आए, हाथ उठाना तो कभी भी सही नहीं हुआ ना.
That is only I'm telling. This violence is not correct. But what are the reasons behind this violence? That I'm trying to explain. Definitely, violence is not good. Violence should not happen. But there are the factors which are responsible for this violence. जैसे पेशेंट फैक्टर हो गया, डॉक्टर फैक्टर हो गया, और एक फैक्टर है सिस्टम का. सो इंफ्रास्ट्रक्चर इन मोस्ट ऑफ द इमरजेंसी डिपार्टमेंट और मोस्ट ऑफ द अदर डिपार्टमेंट ऑल्सो इज नॉट वेल डेवलप्ड. एंड कि सपोज किसी पेशेंट को सीटी के लिए अगर 15 मिनट लगना है, वो पेशेंट को हो सकता है कि आधा घंटा 1 घंटा लग जाए, और उससे वो पेशेंट का जो अटेंडर वो खुश ना हो, उसी के बेसिस पर लड़ाई हो गया. तो ऐसा भी सिचुएशन होता है.
हम पेशेंट के अटेंडेंट को खुश करने के लिए बैठे ही नहीं ना.
That is correct. We are not, but we need to tell them, we need to communicate to them. If it would have been much a better situation कि हम communicate करके उनको बोल दें. See, अगर 100 बार वायलेंस हो रहा है तो उसमें से ऐसा हो सकता है कि 20 बार वो अवॉइड कर सके विद गुड कम्युनिकेशन. आई एम नॉट टेलिंग द डॉक्टर इज एट फॉल्ट, आई एम नॉट टेलिंग द अटेंडर इज द फॉल्ट.
आपके हिसाब से क्या पॉलिसी लेवल चेंजेस होने चाहिए ताकि डॉक्टर सेफ रहे?
Policy level changes is the same. So whatever factors I have told, the patient factors, whatever are the attendant factors, awareness factors, system factors, infrastructure factors, if this could have been worked upon, it will be better. Currently, even Niti Aayog has done a research of health violence on the healthcare workers, and based on that, they have come out with certain factors, which will mainly this कि मोस्ट ऑफ द टाइम्स अग्रेशन होता है कि पेशेंट के अटेंडर को लगता है कि ट्रीटमेंट नहीं मिल रहा है, या उनको कम्युनिकेट नहीं किया होगा कि अब तक क्या क्या हो गया है, या फिर ऐसा होगा कि किसी इन्वेस्टिगेशन के लिए वो वेट करें पर बहुत लंबा वेटिंग लाइन है. समटाइम्स ईडी इज डिवाइडेड इनटू ग्रीन, रेड एंड येलो जोन. सो येलो जोन में ऐसा होगा कि वो पेशेंट आया है 11 बजे, बट उसका ट्रीटमेंट अभी तक, मतलब जो इन्वेस्टिगेशन उसका होना था, सपोज रेडियोलॉजिकल इन्वेस्टिगेशन, वो अभी तक नहीं हुआ. क्यों? बिकॉज येलो में, रेड में बहुत सारे पेशेंट हैं. तो टाइमली वी डोंट वर्क ऑन टाइम है, वी वर्क ऑन रिस्क. जिस पेशेंट को सबसे ज़्यादा डिटेरियोरेट होने का रिस्क है उसका इन्वेस्टिगेशन पहले होगा. बट दैट इज, पीपल आर नॉट अवेयर ऑफ दैट वर्किंग सिस्टम. पीपल को नहीं पता है कि येलो में इतना टाइम लग सकता है.
उसी के लिए तो मेडिकल कॉलेज जाते हैं, ये तो वहाँ पता चलता है ना.
दैट इज ओनली दैट इज करेक्ट. दैट इज व्हाई वी शुड गो टू मेडिकल कॉलेज, बट दिस अवेयरनेस इज स्टिल नॉट देयर. दैट इज द सिचुएशन.
हाउ कैन यू गेट द पीपल टू बी अवेयर ऑफ दिस सिस्टम?
People need to be aware of the emergency department. People need to be aware of the emergency system, how it works. कि हो सकता है कि we can put banners कि येलो में अगर आप आए हो, आपका पेशेंट इतना सिक नहीं है, तो आपको हो सकता है कि इतना वेटिंग लिस्ट हो, वेटिंग टाइम हो, उनको कम्युनिकेट कर सकते हैं.
वो तो डिपार्टमेंट में लगा सकता है. एवरी डिपार्टमेंट कैन पुट इट आउट.
इवन डिपार्टमेंट में लगने के बाद भी ऐसा होता है.
और क्या कर सकते हैं?
यही तो बोल रहा हूँ, सिस्टम लेवल पे चेंजेस लाना पड़ेगा.
क्या?
यही अवेयरनेस वी हैव टू इंक्रीज. वी कैन bring make people more aware of how emergency system works, or how, like, wherever violence is happening, what was the factor behind it and how it can be mitigated by making policy level changes at the level of system. It won't happen if we do in one particular hospital or 1 or 2 hospitals.
सिस्टम में एम्पैथी कैसे लेकर आए? मैं आपसे पूछ रहा हूँ कि मैं एक यंग डॉक्टर का पर्सपेक्टिव जानना चाहता हूँ. आपने अभी तक इस साइड से काम किया है जहाँ पे आप अभी तक सर्विसेज देते आए हो.
Correct.
Once you start becoming consultant, it's more of a supervision. You have your own work also.
Yeah.
But जब आप एक सिस्टम के नीचे से उतर के आते हो, निकल कर आते हो, तो आप देखते हो कि आप पे कितना प्रेशर बन रहा है. एम्पैथी हम कहते तो हैं, लेकिन एम्पैथी कोई देता नहीं है. आज जैसे आपने बताया कि आपने अपने JR1 के साथ टॉक्सिसिटी मेंटेन नहीं करी, दैट्स अ गुड वे टू स्टार्ट गिविंग एम्पैथी. आज सिस्टम में जब आप SR बने हो, यू सी पेशेंट्स कमिंग इन, यू सी, आई एम श्योर कभी ना कभी आपको एग्रेशन, पैसिव एग्रेशन ही मिला होगा. एम्पैथी को कैसे लेके आया जाए सिस्टम के अंदर?
So I feel कि empathy should come not in the PG level. It should be started from the MBBS curriculum only, where there should be a course, or it should be integrated into the curriculum कि how to empathize, how to, like one of the important factor in this is how to break bad news in the patient. कि कभी किसी के साथ बहुत sick है या death हो जाता है तो कैसे break करे. Because even we had done a study in JIPMER, one of my senior, कि उसमें they found out कि if we don't break the bad news properly, even if the environment is not good of breaking the bad news, there can be so much of post-traumatic stress disorder for that patient attender. They will go into taking medications for that also. It will be so degrading for them.
As the government has started giving communication in MBBS.
Communication now, now the system is slowly evolving. The people are getting to know that it is also an important factor. So there are classes of communication skills, but again, then people are not made aware of why it is so important. So अगर मैं as a MBBS डॉक्टर, मेरे को एक है मेडिसिन का क्लास है, एक सर्जरी का क्लास है और एक कम्युनिकेशन का क्लास है, तो मुझे तो पक्का है कि मैं तो मेडिसिन और सर्जरी को अच्छे से पढ़ूंगा और उसमें आई विल ट्राई टू कुछ ना कुछ करके आई विल जस्ट अटेंड एंड गेट अटेंडेंस. So this has to be made aware in the early level of the career कि ये communication becomes so important later in the life. So one of the thing I feel that can be integrated in the initial curriculum कि what is empathy, how to empathize, how to keep it in control. Over empathy as well as under empathy, both are bad. Over empathy में कभी-कभी I have seen situations where that resident has become so drowned, it is like the second victim phenomena. First victim is कि patient का death हो गया तो patient attenders are sad. The resident takes it on himself कि maybe मैंने कुछ गलती कर दी इस वजह से ऐसा हो गया, and they go into the downward spiral. So that awareness only is not there. So it is very important to bring that mental health part in the system. Not even in emergency department, it is needed, very much needed, but also in other departments also. So this has to come from the ground level. This can't be introduced when you have already become the resident. Previously it was not there. Maybe now certain MBBS curriculum are integrating it. So when I was an MBBS student, I was not taught. Even I don't remember also even I was taught, because हमने उसको इतने ध्यान से करा ही नहीं होगा, because we are not aware कि आगे जाके इतना important हो जाएगा.
नहीं, शायद मैं इस मीडियम, क्योंकि हम बात कर रहे हैं दोस्तों, आप जानते हो आई एम वन ऑफ AIIMS मेंटल हेल्थ एम्बेसडर्स. तो AIIMS ने बहुत सारी हेल्पलाइन निकाली हैं. आपको कभी भी ऐसा कभी फील हो रहा हो वेयर यू आर फीलिंग गिल्टी, यू आर फीलिंग स्ट्रेस्ड, एंशियस, ओवरवर्क, डिप्रेस्ड, any mental health problem that you are facing, please contact. I really believe in that AIIMS initiative and I really believe it can help. बहुत छोटी छोटी चीज़ें होती है, when we start doing it हम mentally थोड़ा light feel करते हैं. And please, इससे पहले आपके दिमाग में कोई extreme step की बात भी आए, do call up. We are not judging you, we stand by you. All right, we are with you. आप कभी भी अकेले नहीं हैं, ये बात याद रखना please. Let's talk numbers. Like post your MD, and you are the best person to answer this. Post doing your MD, आपकी पहली salary क्या थी?
So for me, I was in an INI institute. During the MD also you get stipend, which is around 1 lakh in hand. Post MD, as you become an SR, it depends on the institute you are joining. So if you join an INI institute, or so most of the times it will be around 1.4 to 1.5 lakhs in hand. If you join an academic INI institute, if you go directly into a private setup, it depends on the city tier. So if there is a corporate hospital, he might give you 2 to 3 lakhs per month also. In the initial post MD only, it becomes more and more if you have more experience, more research portfolio, and if you bring more to the department. Like you want to bring more quality improvement, you want to bring, you can negotiate based on that. But as an MD and post MD, the salaries vary a lot in India. If you are in a state medical college, state government medical college, it will vary based on the state. So in Delhi, it is almost equal to the INI. But if you go to Rajasthan, it is much, much lower as compared to the INIs. Rajasthan, it will be mostly 30 to 50,000 in hand for an MD person as a stipend, which is like, it's like we are so underpaid in that. you can't imagine. I can't tell it also. So the kind of things you're putting in.
मुझे सही में हंसी हंसी आती है सुन के ना,
Yeah.
मतलब मेरा सीरियस होने का भी मन नहीं करता है कि हम ये किस देश में रहते हैं यार, जहाँ तुम पीएन की सैलरी इन्होंने 50,000 से ऊपर कर दी है, और आज एक एमडी करने वाला डॉक्टर, एमडी का मतलब हो गया 6 साल की एमबीबीएस, 3 साल की एमडी,
Correct.
9 साल के बाद आपको 30 से 50,000 रुपये ऑफर हो रहा है.
Correct.
अब सोचो कितना मजाक के देश में रहते हैं हम लोग.
That is correct.
पीएन की औकात ऊपर है हमसे. ठीक है, तो मतलब मैं जेन्युइनली में कभी ना सोच के लगता है कि कहाँ है यार, क्या होगा देश का ना. आपको लगता है कि इमरजेंसी मेडिसिन इज अंडरपेड रिलेटेड टू अदर ब्रांचेस?
I won't say it related to other branches. Emergency medicine, all the branches are underpaid actually. In the initial career pathways, सब branches का same ही होता है.
बट 5 years down the line,
5 years down the line, it depends how you negotiate. It depends on your own portfolio. कि if you have a good research portfolio, you can earn very well in the corporate setup. In the academic centers or the institutes of the government institute, it is same. It is same profile that associate professor gets this much pay, assistant professor, and higher. As you go higher, as you get more into administration, the pay will increase. The pay differs in the corporate setup, but it will be more dependent on you as a person. So you can range from 2 to 5 lakhs per month also, based on what you bring to the department. That you have to negotiate and bring based on your own portfolio.
इसमें आपको क्या लगता है, व्हाट इज द लॉन्ग टर्म ग्रोथ ऑप्शंस?
हाँ, so why emergency medicine is important in India and why long-term growth option is in India? It's an evolving branch, first thing. Second thing, it is something which is needed in countries like LMIC, like India. It is so much needed that currently our pre-hospital system is so bad that we don't stand anywhere in the global standards. So there are so many gaps which can be filled, which you can work upon, and you can build financially on it also. Like you can make people more aware about it. You can give education, lectures. You can bring on programs. You can tie up with the government policies. You can start up your organization and you can tie up with the policies to make those things better. I have heard this from one of the entrepreneur. I maybe have, maybe in the first or second year of MBBS, one of my father's friend, he used to tell ki, economically you grow only when there is some gap. You find a gap and you have to fulfill it. So I feel कि इंडिया में इमरजेंसी मेडिसिन में बहुत सारे गैप्स हैं. If you find a niche, I feel कि other than the academic part where you have lot of time, you can build up on that related to the medicine and then you can build financially more on that.
So tell me, how do you see AI changing this branch in the next 10 years?
In this branch, I don't feel कि AI डॉक्टर्स को रिप्लेस कर सकते हैं, एंड आई डोंट फील कि कोई और ब्रांच में भी ऐसा हो सकता है. बट इट कैन बिकम वेरी हेल्पफुल इन इमरजेंसी मेडिसिन. Emergency medicine workflow grows from pre-hospital, hospital, and then disposition. So AI has role in all these three factors. Pre-hospital AI role is कि to identify कि कौन सा ऐसा area है, like we can put AI language models कि कौन से area से कौन से cases ज़्यादा आ रहे हैं, उस basis पे वैसा awareness कर सकते public में. We can create awareness about stroke, MI and all, जो कि time sensitive matters होते हैं. We can create awareness about CPR, कि how CPR becomes very important in the initial 10 seconds. In ED में triage होता है. Triage में how AI is important, it can recognize patterns कि ऐसे 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 vitals है तो patient बहुत sick है, तो इसको पहले prioritize करना पड़ेगा. तो based on that, many people are already working on these language models और ऐसे AI based triage systems are coming. Even one of my professor in consultant in JIPMER has also tried this and we are working on it. कि AI based triage we are trying, which is a substitute right now, but maybe with time as we give more inputs to it, it will become a good triage thing. Why AI is important is कि अभी जो workload है on an emergency physician about administration, about triaging, about this and this, it can reduce little bit. So the same work can be done by a lesser number of which is normally the situation in an emergency department. There are never enough healthcare workers available because you never know कि कब कितने cases आने वाले हैं. Thinking about disposition, तो disposition also based on the diagnosis we feed in language models में we can think कि इस patient को इस यहाँ पे dispose करना है, यहाँ dispose करना है. And one of the major factor in emergency medicine is seeing the patient workflow. पेशेंट वर्क फ्लो इन द सेंस कि अभी इस डिपार्टमेंट में इतने बेड्स खाली हैं, इस डिपार्टमेंट में इतने बेड्स खाली हैं, सो इस डिपार्टमेंट के इतने केसेस वी कैन मूव ऑन सो दैट वी कैन रिसीव न्यू पेशेंट्स. सो इसमें भी AI कैन हेल्प कि they can maintain a status of the bed status of the hospital कि हाँ भी हम इतने ऐसे patients हैं जो emergency department से further care के लिए उस department में shift कर सकते हैं. तो yeah, it is helpful. It can decrease the workload a lot, and people are already working on it on these language models. So maybe in next 5 to 10 years we might see them introduced into the system.
What do you think about emergency medicine training in India? Is it like compared to Western countries?
In India, emergency medicine started in 2009. So we are still in the second decade of it. And in the Western countries, it has already been 4 or 5 decades. So currently, we don't meet their standards, most of the departments, but there are certain Indian departments like in AIIMS, then JIPMER, there are many other KMCs there. There are many departments where it meets the global standards. But the problem with Indian emergency medicine right now is that there is no standardization of care. What care in an emergency department I will receive in JIPMER, you might not receive the same level of care in a periphery center. So one of the goal which we are working on currently, the policy makers in the emergency medicine and the us, is standardization of care. So for that, half of the step has already been taken. There has been a curriculum which has been released by the government of India that this is must to know for any emergency physician, for any emergency department to work. And then and it is slowly getting implemented so that the standardization of emergency care happens not even in the best tertiary care center, even in the periphery most center. So if a patient comes on stroke in the periphery, he should also get thrombolized and sent to the particular center. This is very nicely written in one of the article. It is by an Indian doctor, Dr. Yogesh Jain. He has written Democratization of Medicine, Bedside Medicine. So where he discusses a case of a 51-year-old laborer. He used to work in main AIIMS, then now he has gone into a periphery center, so he is helping the community there. तो उन्होंने लिखा है कि एक 51-year-old का लेबरर था, उसको हेमीपेरेसिस हुआ, उसको वीकनेस हुआ, सडन ऑनसेट, लुकिंग लाइक स्ट्रोक. So in stroke is a time-based diagnosis. So initially within 3 to 4.5 hours, if it is a stroke, you have to thrombolize it. But the problem with that patient is there is no CT machine in that periphery center. So he has to go travel for 1 hour, go get a CT done, then go to a radiologist or someone to interpret the CT and come back. So that only takes 3 to 4.5 hours. So all these time-sensitive matters can be really improved on, which will increase morbidity as well as lot of mortality in countries like LMIC. So this is something which we are working on. And there is this EMS part, the pre-hospital part. There been a very big multi-centric registry which is going on, and we are integrating with the AIIMS and the ministry, which is developing the pre-hospital EMS system of India. So we are taking, it is like a disaster feedback loop. So we are taking what currently is there, what can be improved, then we are implementing small change, then we are again reassessing what change brought, then how it is changing. So everything is work in progress. Maybe in next 10 years, the state will improve a lot. It will still require a lot of improvement, but slowly changes are coming.
इसमें तो इस फील्ड में तो अब DM भी है.
Yeah. So
आपने सोचा अब DM करने का?
Initially मैंने join कि मैंने सोचा था कि I might go for DM critical care after this. But the thing is कि एक बार if I go into the DM critical care, I'll miss the emergency part of it. The very motto I joined this department to fill those particular gaps in the healthcare system. So I have taken a step back from it. For as of now in my mindset, I am there कि मैं MD emergency medicine में रहूँगा. I won't do MD. I won't do DM. Because I feel कि there is lot to do in this department as of now. And if this department builds up in the country, there might be lot of change in the healthcare system, what we are seeing right now. And most of the time, people who are good in this, they take up DM and then they go from this. So in the end, the department suffers.
DM इसमें एक ही है कि कोई और ब्रांच भी है?
Main branch is DM critical care you can do. Then medical oncology में DM you can do. And then you can do fellowships. You can't do DM अभी, but fellowships. So उसके भी अभी options. Since it is not fully developed branch, we have not gotten opportunities to do DM in other branches. But slowly it is working. Many new subspecialties are coming, which are already there in West. And some Indian specific or LMIC specific also are coming, like rural medicine, community medicine, like rural emergency medicine, community emergency medicine. Then there is wilderness medicine. There is particular hospital which is working on it. Then there is subspecialties on POCUS based, which is ultrasound use in this. So you can, many fellowships are coming, many subspecialties are coming, but it will take time. So it is in work in progress, and people are actually working on it, and it will bring a great change in the next 10 years.
थैंक यू सो मच. अब हम थोड़े से रैपिड फायर क्वेश्चंस करेंगे आपके साथ. सिंपल है. यू हैव टू बी सुपर स्पॉन्टेनियस एंड सुपर ट्रूथफुल.
Correct.
ठीक है सर, करें शुरू.
Yeah.
वन हैबिट यू स्वेयर बाय.
One habit I'll tell is I try to learn something every day. Like it's not always medical. It can be something related to finance also. It may be something I read about, some emotional experience, something like that.
टी और कॉफी.
Coffee, definitely coffee.
नेटफ्लिक्स और बुक्स.
Netflix.
लास्ट सीरीज.
Last series I watched is Stranger Things का last season.
अच्छा था ना.
हाँ हाँ.
वन प्लेस इन द वर्ल्ड यू हैड लव टू विजिट.
One place in the world I love to visit is it is actually कि I want to go it in the same state which I went. So in my MBBS का this MD का last year in the 5th semester I went to Rome for a conference. I went to Rome as a medical student and I roamed around. So I want to get the same experience again. It is not about the place, but it is more about the experience that I want to relive.
A movie you have rewatched more than twice.
Interstellar.
बहुत अमेजिंग मूवी यार. Especially the soundtrack.
Yeah, the Hans Zimmer. Now there are multiple concerts happening about it. They will replicate the same sound again. That sound is like that is the sound which will make you think, but it is very noisy also. So it is very interesting.
Thank you so much, Dr. Arihant. You have given us a lot on emergency medicine. Change the perspective. कि कैसे आप सोचते हो और कैसी वो है, उसमें बहुत ज़्यादा अंतर है.
I'll just tell one thing कि being an emergency physician, you are jack of all trades, but you are master of resuscitation and you're master of time. So you can help the person who is in the worst of the situation with the best you can do. So if you feel कि you are up to it, कि you have that personality type to do this, do consider this branch.
Thank you so much, and I wish that you become one of the best emergency physicians in the country in the coming future. And thank you so much, everyone, for watching today's podcast. I believe Dr. Arihant has given us a lot to think about. Emergency medicine has a good work-life balance. I am surprised too. But again, let's learn with somebody who has lived the tale. JIPMER, AIIMS is our ship. A young doctor telling us what is the reality today. That's what we all love about. Thank you so much. And as always, do not forget to like, share and subscribe. Thank you and God bless you.